at the AutoMed meeting, and I'm going to, in the next 10-15 minutes, just give you a little bit of background to how FRAX is being used in the UK. So those are my disclosures. So just a quick recap on why we sort of needed fracture risk assessment tools in the first place. Obviously, osteoporosis is a common disease. We've heard many talks this morning about the burden of disease, the risk factors for the disease, and the fact that osteoporotic fragility fractures largely probably fall on primary care in terms of their long-term management and prevention. And most of us sitting here in the audience have a specific interest in osteoporosis, so we feel that we have an expertise in osteoporosis, whereas many primary care physicians obviously have to look after many other long-term morbidities, and osteoporosis is just one of those. So any help that can be provided in terms of risk assessment and management advice is worthwhile. So we developed the FRAX tool, and FRAX has been around now for 10 years. In April this year, it was 10 years since the launch. In the UK, as many of you will know, we have this wonderful body called NICE, which is the National Institute for Clinical and Health Excellence. And in 2012, they embraced the approach of not just screening, or not screening for osteoporosis, but not just assessing the risk of osteoporosis, but actually assessing the risk of fracture. So we weren't no longer being obsessed with a T-score of -2.5. It was the risk of fracture that was important. And they published this short clinical guideline in August 2012, and basically said that we should consider the assessment of fracture risk in all women aged 65 years and over, and all men aged 75 years and over. Below those ages, in men and women, you could consider fracture risk assessment if they had an identifiable risk factor, so it was more of a case-finding strategy, so if they had a prior fragility fracture or glucocorticoid use or so on. And then in the younger population, under the age of 50, no need for fracture risk assessment unless they had a major risk factor such as glucocorticoid use or previous fracture. Now, as some of you will be aware, we have more than one fracture risk assessment tool available to us in the UK. We also have a tool called QFracture, which is embedded in one of the GP software systems. And for the sake of time today, I haven't really got to go into the similarities and differences between those two tools. But there are differences, and those differences were somewhat swept under the carpet by NICE, who just said that you could use either FRAX or QFracture to calculate the 10-year predicted absolute fracture risk, and I put absolute fracture risk in red on the slide there, because it implies that both tools will give you the same absolute fracture risk assessment, but they give fairly different numbers. The second point they said was, do not routinely measure bone density to assess fracture risk without prior assessment using FRAX or QFracture. So that was the guidance in 2012. So this is a screenshot of the FRAX tool. And it's probably difficult to see from where you're sitting in the room there, but the important thing in terms of implementation of FRAX in the UK was that we launched FRAX in April 2008, and we knew we had to follow up with a clinical guideline very shortly thereafter, and we produced the National Osteoporosis Guideline Group guidance about 4 months later. And you can see that in the UK tool, in addition to getting the two numbers of major osteoporotic fracture and hip fracture, you get this additional button which says View NOG Guidance. So the GP gets the numbers, but then they get this button. If they're not sure what the numbers mean, they can click on that button, and that takes them through to the guidance website. And on the guidance website, if they haven't done a bone density, then they see an image that looks like this. It's a sort of traffic light system. If you're at low risk, intermediate risk in amber, or high risk in red, then that has implications for either treatment if you're in the red zone, or measurement of a bone mineral density if you're in the amber zone. Again, the nice thing about these two guidelines, or two websites being linked, is that if the doctor clicks on the treat button here, then that treat button remembers that it's a woman rather than a man, or it could be a man. It remembers whether they're on glucocorticoids or not. It remembers their age, and then that tailors the advice that comes up on the pop-up box to help them decide what to do. And in February this year, NICE launched its quality standard for osteoporosis, because they hadn't defined clinical intervention thresholds. When they did the risk algorithm in 2012, they just said, we don't deal with intervention thresholds. But this year, they endorsed the National Osteoporosis Guideline Group thresholds. So if you measure the bone mineral density and you bring it back through, so we're measuring the bone mineral density not to get a t-score of minus 2.5, but to take that t-score and feed it back into the fracture risk calculation, because it's yet another risk factor for fracture. And then when you go back into the guidance, the amber area has disappeared, and you just simply have the patient lying in the green or red areas with indications for treatment. So a few years back, we were able to use Google Analytics to go back in behind the two websites, the FRAX website and the NOG website, to look at access to both of those tools from within the UK. So this is just limited to access from within the UK. This is over the year from 2012 to 2013 from memory. But this is the FRAX access map, heat map if you like. You can see there's large dark circles here around Glasgow and Edinburgh, a bigger circle around Belfast here. There are 3 or 4 big dark circles in the background here that you can't see, because they're also covered by this sort of measles confluent rash of users of the FRAX tool from within the UK. And on the right is the NOG access, and it's really a spot the difference competition. They're virtually identical. And we know that about 2/3 of the calculations that are done on the from the UK are followed by that result being taken through into the NOG guidance. And we also know that 75% of the assessments come through without the FRAX, without the femoral neck BMD score included. So these are assessments that are being done to decide whether the patient needs a bone density assessment or not, and that's exactly in line with the suggested use by NICE. So in the slide, I've shown the slide previously, they said consider assessment of fracture risk in all women aged 65 years and over. So it's not a screening recommendation, but it's a sort of strong consideration to consider fracture risk assessment just on the basis of age alone. And that led us back in the early or mid-2000s to consider what a screening strategy might look like. And this is the SCOOP study that we published in the Lancet at the beginning of this year. So in this study, we identified about 100 GP practices in 7 centres in England. We wrote to all the women aged 70 to 85 years on their lists who had not been excluded. Some of them had been excluded by the GPs because they were already on osteoporosis medications, or they had dementia or some other condition that would limit their participation. Of those who agreed to take part, they provided baseline information. That baseline information was used in one arm to assess their fracture risk, and if they were at high fracture risk, they were sent for a DEXA, and then the T-score was taken back in, and they were calculated to be at high risk or low risk. In the other group, the FRAX questionnaire was untouched to the end of the trial, and then we were able to go back and assess the FRAX questionnaires in that group, and that group was just left to normal clinical care. They just got a letter saying, thanks for taking part in the study, your GP is responsible for your osteoporosis management in collaboration with yourself, but we're taking no further action. So the study was predicated on FRAX hip fracture risk, and this is just looking at the ability of this tool to predict hip fractures in the population. So this is just in the control arm. And you can see this is quintiles of FRAX hip fracture probability measured without BMD or assessed without BMD, because no one, or very, very tiny numbers in the control group, got bone densities under the care of their GP. But you can see here that there's a nice stepwise increase in the incidence of hip fracture based on the quintile of baseline FRAX hip fracture probability. In the study, this is the control group with just over 6,000 patients in each group. And you can see that they're on average about 76 years of age. About 1 in 4 of them had a prior fracture, very similar to the data we saw from the fracture risk factor study presented earlier today. You can see the other risk factors here. They're very well balanced between the two groups. And then within these 6,233 women in the screening group, the women who came through the process, through the DEXA final assessment of high risk, we had just under 900 who were identified to be at high risk. As you'd expect, they're older, they're slightly thinner. They're in the high-risk group because they've got higher prevalence of prior fractures, family history of hip fracture, and so on. And you can see down at the bottom here that the 10-year hip probability in the population as a whole was about 8 to 9%, but in the high-risk subgroup it's about 18%, so twofold higher. And what we found was that this is looking at the incidence of hip fracture over the 5 years of follow-up. And you can see the placebo group, or the control group, it's not a placebo group, it's an open control group, is here in the light grey line, and the screening group is in the dark blue line. And we saw this 28% reduction in hip fractures, which was highly statistically significant. The number needed to screen to prevent one hip fracture is very favourable at 111. The actual number needed to treat to prevent one hip fracture is only of the order of 15 to 16, so it's really good, good numbers. Of course, we'd love to do a comparison between the control and the screening groups to see how the effect was mediated, but we don't have bone densities in most of the control arm. So what we've been able to do is just go back and do their 10-year probability of hip fracture without BMD at baseline. If we had no effect, if the effect of screening was mediated by treatment in the high-risk patients, then we should expect to see a line that looks like this. Little or no effect down here at the lower hip fracture probabilities where there's no treatment in either arm. But as the treatment became more frequent, you can see this reduction in hip fracture risk. And that's the high-risk population. The median value is here, and the median risk in the high-risk population is almost the same as the 90th centile in the whole population. So the implications of SCOOP for the UK is that we are putting together documentation to discuss this with the Department of Health and the UK National Screening Committee. We can conclude certainly that women aged 70 to 85 identified at high fracture risk based on FRAX hip fracture probability are responsive to appropriate osteoporosis management. We saw a 28% reduction on average, but if you pick patients at particularly high risk, for example at a hip fracture probability of 32%, the reduction was of the order of 53%. And if we implemented the strategy just exactly in the same way that SCOOP was implemented, so the same uptake, the same participation rates, then we would save something like 8,000 hip fractures a year out of a total of about 75 to 80,000 hip fractures that occur each year. So about a 10 to 12% reduction in hip fractures. And as I say, future plans are underway to identify how we will implement that. So fracture risk assessment is widely used in the UK. Guidance incorporating FRAX is increasingly being adopted, and the NICE accreditation has really helped in that regard. But I think that one of the things that I would recommend most is that the automated links between the tool and the guidance, actually in these days where everybody is essentially computer-based or even smartphone-based, provides a very direct link between the assessment and the advice. And with that, I'll just thank everybody who took part in the SCOOP study, most importantly to the Medical Research Council and Arthritis Research UK, who are just relaunched recently as Versus Arthritis in the UK. They were very kindly funded the study. Thank you very much.
Thanks, Eugene. And now this presentation is open